Hello, everybody. We are live, and thank you for coming back, and welcome back to the ARPneuro Q&A show. And we have a great show today. We have a few guests here, and in Matt's place, we have Colin taking over. So Colin is going to be going through the slides in just a moment. And we have a wonderful, exceptional guest, and we can't wait to get to him as well. We have Dr. Debono, and I will formally introduce him after Colin. But Colin, good to see you, bud, and
Yeah,
floor is yours.
absolutely. Happy to be here. Thank you, everybody, for joining the show today. For those of you that have not been around, Matt Dell, who is our business development officer, he's out of town this week, so I'm going to be taking over and kind of introducing a little bit about what ARPneuro is, some of the things we've been working on, how our technology works. As always, throughout the show, about an hour, feel free to hit that question box down there. And, Jake or I or Dr. Debono will get to those and kind of as they come in. So let's go to the next slide here, Jake. What is ARPneuro Therapy? So ARP, Accelerated Recovery and Performance, right? That's the acronym for ARP. This technology is not new, guys. This thing has been around for over 20 years in the US. It's really kind of been a through the grapevine type of deal, right? So the manufacturer, ARPwave, this technology was developed in the early 2000s by a guy named Dennis Thompson, right? And these guys really had one goal in mind, which was to work with professional athletes. And they had a lot of success doing that, right? There's a 95% success rate, over 2,000 athletes treated using this technology. And it's proven to be a breakthrough technology for a lot of people that have been dealing with, acute injuries, chronic pain, or really just wanting to optimize the way their body moves and performs. The secret kind of took a little while to get out. You can go to the next slide there, Jake. So there's a lot of people that have been using this thing, right? Like I said, 20 years of use through ARPwave. We have the NFL, the MLB, NBA, all major professional sports, college, even Olympians. So as this technology kind of started to spread, the word started to get out, it trickled down to the general population, the general public, people like you and me, right? A little bit of story about ARPneuro. We got the distribution rights from ARPwave in North America to help bring this to the general public. Right. So the owner of our company, a guy by the name of Chip Turner, was having some issues with his wrist, with his hands playing golf. Went and saw several surgeons, with most of them telling him he was going to be needed to go under the knife. He kind of got to one guy who said, "Why don't you go try this ARPwave situation, right? This technology, see if it works. If not, you're probably going to need surgery." Chip went, found a guy in Chicago that was using this, a guy by the name of Dr. Brian Miller. Went through 5, 6, 7 sessions, never actually needed to have the surgery. So that was about 5, 6 years ago. Immediately, Chip, being the guy he is, really wanted to help out. Just kind of said, "Hey, why isn't this everywhere, right? Like, why have I had to go to several surgeons before I was even told about this as an option?" So that's kind of, how the conception of ARPneuro came about. So we've been working really hard on getting this kind of out to the public, getting it in clinics, getting it in the hands of the people that have been battling pain, injuries, or like I said, just want to perform at a higher level, getting it in the hands of those people, right? So Jake, can go to the next slide. So much so that, a lot of people have taken notice, right? Logan University, as of a few months ago, brought us on, added us into their curriculum, and is actually helping us kind of study a little bit more about why this works scientifically, right? We have a lot of outcomes, and you'll see kind of throughout, if you start following with ARPneuro, we're all about outcomes, but we want to know a little bit more about why it works. We know it works, but yeah, having Logan on board, they dedicated an ARPneuro clinic in St. Louis to kind of go through some of those studies, and they graduate over 400 doctors of chiropractic annually. So we're super excited to kind of have them on board. Dr. Debono will talk a little bit more about that later on. Jake, can go to the next slide. All right, so how to choose ARPneuro Therapy. We have 2 devices here at ARPneuro, right? The RX100 is our class 2 medical device. This is a clinical unit, right? This is our big dog. This thing requires a prescription from a medical professional, right? So you need to have doctor oversight in order to use this. It contracts 500 times per second at a cellular level, and it's a direct current wave, right? And it's biphasic as well. So what that means is we're able to actually go through and diagnose and understand really neurologic origins, where there's some sort of breakdown in communication, if you will, between the nervous system and the fascial system that's causing people to develop habits in their body, compensatory patterns that we call them, right? That lead them into down this road of chronic pain or injury and things like that. This is really recommended for people that have a pain level of 6 and above. right? So anybody that's really struggling, that really feels like they just need a breakthrough, this is probably going to be what you want to lean towards. And on our website, we have a clinic finder where you can actually go through and type in your zip code and identify kind of where the nearest clinic to you is in the country, that you can go check this out and get a little bit of kind of a taste of what this is like. ARPneuro at Home, this is our PRS system, right? This is an over-the-counter device. It can be used at home. It can be used in the gym. I'm sure everybody on this call, Jake, Dr. Debono, you guys can attest that this thing is super, super convenient and still very powerful. It's the same technology as the RX100, right? So what that means, it's the same exact waveform. It's direct current. It's biphasic. The only difference is it's a little bit of a lower level, right? So it's a little bit safer, a little bit easier to use. It's 245 contractions of DC per second. This is used for people that really want to kind of just maintain the level that they're at, right? Maybe they go in, they use the RX100 in the clinic. This is to make sure that they don't plateau. Maybe they're going on a vacation. They want to throw this in a suitcase. Maybe they're going to the gym. They want to really optimize their workout and get the most out of it. This is a very, very powerful little device. And like I said, anyone that's used this thing can attest to the fact that it really does get the job done for most ailments, right? You can go to the next one, Jake. So what is ARPneuro Therapy? We kind of got into this a little bit, but what this thing does is it gets down to the neurologic origin of pain, right? This is not your standard TENS unit. It works a lot differently with the body. The only similarity, and we'll get into this a little bit later, is that it's electric, right? But I like to make a joke sometimes with some of the people that I work with. There's a difference between a Tesla and a refrigerator, right? They're both electricity, but there's a lot of differences, and kind of just the way that this waveform is going to interact with your central nervous system. And we're excited to hear how Dr. Debono is going to go into that a little bit later. But some of the indications we have are to alleviate pain, prevent injury, accelerate the healing of soft tissue with the depth of penetration of this wave. We're going to increase range of motion. That's always something that we can almost guarantee every single time. Range of motion is usually going to increase regardless of the ailment you're working on. And then obviously muscle reconditioning and re-education neurologically is going to lead to a lot of these things that we talked about above. Jake can go to the next one. So patient benefits, like we said, accelerate recovery. Guys, this is something that we can use if you were injured. This is something we can use if you are sore from the gym. This is something we can use if you have a chronic back pain issue or a chronic hip issue and you have a 6-hour flight coming up, right? We can put this on in a lot of different scenarios to really help your body be comfortable, recover, and actually keep that recovery, right? This is not just a temporary fix. This is something that's actually going to go in and rewire your physiology to make sure that these changes we're making are actually going to be permanent. We're going to increase performance as well, guys. So improving range of motion, relieving muscle tightness, improving flexibility. This is something that we can put on before a round of golf. We can put it on our legs, on our knees, on our hips before we go, play tennis. I'm a surfer. I put it on my shoulders before I paddle out, and helps me feel like I've already been out there for 30 minutes, right? Things like this. And then also strengthen muscles. I know, Jake, you can probably talk about this a lot, being, I know you traveled a lot in the past with the PRS, with the RX100. Having this machine is like having a full weight room in your pocket. I mean, 100%. You can contract muscles to the point that it is very, very difficult just to do a body weight squat, right? And the thing that's so great about that is for a lot of people that have, ailments, we don't want to place a lot of stress on our joints, right? Maybe people that are aging but still want to be active. We can build muscle. We can provide blood flow into the tissue to stay healthy and stay strong without feeling like we have to get under a barbell that has 225 pounds on it, right?
Exactly.
Let's get to the next one here.
One thing before you continue on, Colin, we had a question come in. So would you just be able to elaborate when you were comparing the RX and the PRS? What do you mean when the PRS is a little safer?
Safer meaning easier to use, I would say. Not that the RX100 is dangerous by any means. Obviously these are all FDA medical device cleared, right? So safer meaning there's less buttons on it. It's just an easier machine to operate, I would say. You're not going to screw it up, right? It's there's a reason that it's over the counter is because it's more user friendly, is I guess what I meant to say about that.
Cool.
Awesome. Some of these common conditions, I'm obviously not going to read through all these, but it's a very wide range. I mean, we can go through anything from neurologic issues, core weaknesses to prevent back pain, chronic issues. We have people that work with plantar fasciitis, a lot of podiatrists, things like that. And then even some of these really kind of interesting ones, like hard to treat things like TMJ, multiple sclerosis. I mean, there's just such a wide variety. We have, there's a clinic, the Spiro Clinic. Are they in Kansas City, Jake?
That's a good question. I believe so.
Regardless, they work with CRPS, which is, people say it's the most painful human condition on the planet. It's hard to even imagine what these people are going through, and they get incredible results with the RX-100. So the point being is we can really treat a wide variety of issues with these devices. Go to the next one here. Awesome. How does it work? So ARPneuro uses electrical stimulation to safely send a direct current electric signals to the source of pain, right? So we're not working just with the symptom, we're working with the origin here. It stimulates soft tissue, increases blood flow to the source of the pain, and brings rich nutrients to speed up the healing process, right? So as we all know, right, blood flow is paramount when we're talking about recovery. If we have tissues that are damaged, if we have tissues that are inflamed, bringing that and circulating that healthy blood flow, and I know Dr. Debono is going to talk about this a lot more later, it is a huge deal. We combine that with the muscle contraction to kind of strengthen areas that need to absorb future force, and it's really a winning recipe. That's a little bit about kind of, the basics of how this works. And again, we're hoping to hear a lot more about kind of the science behind a lot of this stuff later on with Dr. Debono. Awesome. So, we get this question a lot. How does the ARPneuro PRS compare to, and the PRS again is the home unit, right? This is our take home unit, to compare to a TENS unit, compare to a Compex, right? These are things that people kind of know about. You can go to, a Walmart or a Walgreens and buy a TENS unit for $60. People are going, why would I spend $3,000 on an ARPneuro PRS, right? There's differences, and we could be here talking about this all day, but the main one is the ARP is direct current with a proprietary background waveform. We talked about that a little bit. The direct current wave means that it can penetrate a lot deeper into your body at a safe level, right? So your brain, your body being electric actually works on a DC current, right? So we're basically introducing a current to your body that's already sort of native to it, right? As opposed to an alternating current, which is the TENS, really just mass pain. Basically what it's doing is it's blocking your nociceptors temporarily, right? So you're putting the TENS unit on, you take it off, you might feel good for 20 minutes, an hour, something like that. But really what it's doing is it's like taking a Tylenol. Right? It's not actually fixing anything, right? So we're increasing blood flow 25 times what the TENS is doing. We're contracting muscles about 25 times what the TENS is doing to actually build muscle, not just mask pain. It's super portable, super easy to use. And what we're doing is, like I said earlier, this is not just a quick, temporary, let's put a Band-Aid on this issue, right? This is long-term results. We're actually changing the physiology of the injury itself. And allowing, like we talked about earlier, muscles to be strengthened physiologically, but more importantly, neurologically strengthening the connection to these new muscles that we're building, so they're able to be utilized properly. Go to the next one, Jake. Awesome. We always say here, it's all about outcomes, guys. We have 500,000 patients treated. Like we talked about earlier, about a 95% success rate. So you can go onto our website, arpneuro.com. We have tons of different, success stories. You can kind of, go through, click. There's a little bit of something for everybody. We have, people that are, have dealt with chronic issues post-op. We have athletes at all different levels. So it'll be cool to go in there for you guys to check all that stuff out, to hear a little bit more about how that works. On the next one. And guys, like we talked about earlier, FDA cleared. This is a class 2 medical device, the RX-100. The PRS is over the counter. Safe for all ages. It's safe with surgical hardware. So if you have, screws, bolts, whatever in your ankle, or maybe, something in your hip, some type of anchor, totally safe, good to go. We have contraindications, that obviously, this is a powerful electrical device. Women who are pregnant, that's a no-go. Implanted electrical device like a pacemaker, and anyone with a history of multiple blood clots or known cancer, also a contraindication. So just to keep that in mind. Awesome. So I'm going to now pass it over to Jake, and let's get the Dr. Debono introduction going. Again, guys, thank you so much for tuning in. And please, if you have questions, do not be afraid to hit that question box, and we'll get to them.
I'm not going to let you get off that easy, Colin. You mentioned something I think that was really interesting. There's probably going to be other people out there, but you spoke of an activity that I think this certainly has benefited in the past. You talked about your surfing. Can you explain how that's probably helped that activity? Maybe one of your own personal experiences. I think that would be helpful for a lot of people who are kind of in that same activity.
Yeah. So I initially found ARP. I had 2 hip surgeries before my 20th birthday, believe it or not. And I was playing Division I sports. I was at a pretty good school that seemed to have a good training program, good training room, right? And I had really been exposed to it all from, lasers to ultrasound to, needles and compression and you name it, as far as modalities, and everything I felt, it helped temporarily. And, it was kind of cool to see all these different technologies and learn about them. But I mean, I went through this for years and never really got out of pain, right? I had the surgeries done and everything was technically fixed in my body. But there were just these underlying compensations that, if you don't know about this stuff, you would never know. You just think, oh, I'm going to feel like this forever, and I just kind of accepted that. I had kind of a friend of a friend introduce me to the idea of ARP, and I went and got a couple sessions over a weekend. And it lasted, right? Like, it wasn't like I left and I felt good for a couple hours. It was like I left, and for 5, 6, 8 days, I felt engaged. I felt like my body was working properly again. I almost felt like someone had gone into my hip joints and like kind of sprayed WD-40 in there, which is, I kind of hear a lot of people say that type of thing. But yeah, with the surfing thing, I have an impingement in my left shoulder. I probably have a torn labrum in that shoulder. So, going out, it's a repetitive motion. A lot of people have these sports with repetitive motions. I mean, you're not hitting half your golf shots lefty, right? You're always hitting them the same way. So we like to talk about that type of stuff a lot. If you have these patterns that you're doing over and over and over again, you get tired, and now something starts to maybe shut off or not want to work as, to its full potential. That could lead to problems, right? So with me, I mean, I'll just, I'll take the PRS, I'll stick it on, maybe a teres and a pec major, a lat and a trap, and I'll just kind of go through, my standard, just little warm up. But something about having this on, it feels like it's engaging my brain too. Like, it feels like it's reteaching me how to actually use the muscles I know I'm going to need to use when I'm in the water, right? Which is like I said, I get out there, I feel like I've already been there for 30 minutes.
Yeah.
I wish I knew about this when I was playing sports.
Yeah, we've heard that before, for sure.
Yeah.
Thanks a lot, Colin. Appreciate it. Again, appreciate you filling in for Matt as well.
Happy to be here.
So this individual, I'm sure, probably does not need an introduction, but I'm going to do it anyway. And please have your your full attention to this individual. But we do have the privilege of hosting what I consider an exceptional guest today. He's been an distinguished figure in the realm of chiropractic medicine with over 25 years of experience in the field. He is not only a highly respected academic, but he's also a renowned clinician and researcher. Currently, he's serving as a professor at Kaiser University College of Chiropractic Medicine in West Palm Beach, Florida. His contributions to the field are immeasurable. Throughout his illustrious career, he has held key academic leadership positions. These include Vice Provost of Innovation and New Ventures at Logan University in Missouri, as well as Vice President of Academic Services at National University of Health Sciences in Illinois. Beyond his academic endeavors, he is the visionary and founder of Modus Methods, an initiative dedicated to offering evidence-based education on myofascial therapy. This platform showcases his unwavering commitment to advancing the field and disseminating knowledge to fellow practitioners. With his extensive expertise and comprehensive understanding of chiropractic voice in the field, I want you to join us as we delve into his remarkable journey. We can gain insights from his vast experience and research and explore the innovative advancements that he has spearheaded. So everyone, please give a warm welcome to Mr. Dr. Vince Debono. Dr. Debono, how are you doing, sir?
Good, Jake. I'm glad you said over 25 years when it's rapidly approaching 35 years of practice. So technically that's over 25, so that's good. But,
you look younger than that.
yeah, I started chiropractic when I was 10, so it's pretty. No, I'm very, very happy to be here, and it's been an interesting journey with ARPneuro, and it was first brought on to it by Dr. Miller, who you mentioned earlier, who was actually one of my first students 25 years ago in Chicago, and we've kept in contact ever since he's had a practice. Dr. Miller's a pretty hard guy to ignore, and
true.
He came to me probably about 5 or 6 years ago with this. He was been using ARPneuro longer than that, saying that he's playing with this new therapy or found this new therapy that's having tremendous outcomes. And I was a bit skeptical at first because in my career as a chiropractor, I spent a lot of time in private practice too, but I really drifted towards much more hands-on functional approaches, more myofascial, instrumentated soft tissue, kinesiology taping, and really moved away from a lot of the modalities, the typical electrical stim, interferential current, which was really the kind of the state of the art when I got out of school, but everyone kind of drifted back towards active care, more hands-on, which I was doing too. So I rarely used modalities. But when Dr. Miller said, well, this is a new electrical stim thing, I'm like, yeah, I stopped using electrical stim. So anyway, he finally convinced me to come up, take a look at spent some time in his office and looked at his outcomes. And I'm like, well, this is not. I mean, this is an active protocol that they're using. It's much different, and it's getting a dramatic effect on, cases that I've typically know to be really reticent to getting better or to have a common reoccurrence, like IT band syndromes, plantar fasciitis, where they're getting better and they're back 2 months later. They're getting better, then back 2 months later, which means we're not fixing the source. So, and that was the other thing that really got me interested in talking more about this with Dr. Miller. He said, most of the areas you're treating have nothing to do with the area of pain. And to me, that was always a key, because as I got better and better with myofascial work, I realized most of the areas I work on have nothing to do with where it hurts, because that's not where the dysfunction is coming from. So anyway, that was kind of my introduction to it and why and then what really got me interested, because the theories he was saying of why it's working, well, put it politely, didn't make sense. I'm like, well, wait a minute, let's put some science behind this, because it's obviously working, but what you're saying, I don't know if I buy it. So that's where,
let me pause you there for a second, because that is a pivotal piece of one of our slogans now, based on some things you said, where we don't know why it's working, but we can't argue with the outcomes. And that's what kind of inspired Matt in the beginning when he heard that. It's like, it's really all about the outcomes. And is that one of the reasons that you were kind of convinced that it's something to kind of go into deeper and learn more about?
well, it's a parallel journey to what I did with myofascial work. Because when I first started doing a lot of myofascial work, the theory was you're breaking adhesions and you're doing this, that, and the other thing. And I'm like, yeah, I don't buy that, because I don't think we form true adhesions that quickly anyway. But the outcomes I was getting was phenomenal. I'm like, well, this works, but what they're saying doesn't make sense. So then that brought me down the path of working with particularly at the Stecos out of Italy, where they're moving more away from an adhesion model to a densification model of hyaluronic acid. And that's what's screwing up the spindle feedback, blah, blah, blah. That's not for this. So I took the same approach with ARPneuro Therapy, where, what they're saying, that there's, the original thing was cellular leakage or something like that. I'm like, well, I don't know if I buy that. But then when I started digging into what's actually happening, there's some really good science and some really good evidence behind that, as far as breaking neurological inhibition. It seems of what we're doing with this thing. We're dumping in so much sensory input that it's overriding some of the inhibitions that come from, and these are all known neurological pathways, like arthrogenic muscle inhibition. That's been known for years, that a joint that's injured or a joint that has arthritis inhibits the muscles that are connected to that joint through a sensory neuron. We'll go over that in a little bit with the slide too. And that seems to fit with what you guys are doing, because we're seeing, pretty dramatic strength gains after 1 or 2 sessions with the ARPneuro. Now that can't be physiological. I can't change muscle that quickly. So that's got to be neurological. So I have to be breaking some kind of neurological inhibition, which brought me down that pathway of like, well, let's look at the neuro side of this. Let's not worry so much about muscle phys, but let's worry more about the neurological inhibition that could take place with a muscle. Because to get a response that quickly, it must be breaking an inhibition and not creating a new neural pathway, but breaking the inhibition. I think long-term, though, it can create neuroplastic changes, and we can go over that into a little bit when we dig into the science.
Yeah, absolutely. And just for those that are they're watching or listening, just a reminder, Colin brought this up, but if you have any questions, we do have the Q&A. Just feel free to write it down in the messaging, and we'll try to answer as many as we can. Dr. Debono is going to go into an extensive detail on this, so a lot of your questions might be answered before we even get to them. But feel free to ask questions as we go along, and as Dr. Debono gets into this. All right. And at this time, you're probably sharing your screen right now.
Well, let's take an example. Here's a simple diagram, and this is one of the first ones I was talking with Dr. Miller about, saying, and again, this is for the chiropractors on board or some of the students. I'm going to take you back to neuro here. Sorry. But one of the key components when we look at a muscle and the function of a muscle, the muscle itself has the fibers that contract are the extrafusal fibers. They're the fibers that shorten. That's what people, when they think of muscle fibers, they think of the extrafusal fibers. Remember, inside is an intrafusal fiber, or the muscle spindle fiber. That's the sensor of the muscle. So I know it's been a few years for some of us looking at neuro, but muscle spindles react to tension. So when the muscle spindle is put under tension, it causes the muscle itself to contract. So it's going to cause the muscle to shorten. So that's how we signal the muscle to contract from an external force. Like if I'm trying to lift a weight, that initial lift will cause the muscle to stretch, which will signal the spindle that it's stretching. Then the spindle fires the alpha motor neuron pool to contract that muscle to overcome the weight, right? Interesting enough, on the second lift, more spindles will fire because now the muscle's starting to accommodate. So you actually start to get stronger on your second or consecutive lifts until you start to run out of ATP, and then you start to fatigue. But this spindle, and again, this came from my journey with myofascial, because in the myofascial realm, the blunting of this spindle seems to be by, the gelling of, for muscles to slide evenly, they have hyaluronic acid in there, which is a nice liquid. Essentially what the Stecco's theories were, that in muscles that are immobile or muscles that are dysfunctional, that hyaluronic acid tends to gel up or kind of become like bacon grease and blunts the input from the spindles, why we get dysfunctional muscles. And I could buy that. Now, I couldn't figure out how that affected by ARPneuro, because this is a different mechanism. We're not going in and doing direct stimulus to the muscle with like an instrumented soft tissue. And that's where I started going back into the alpha gamma loop. So the muscle itself, the contractile fibers in the muscle, they're innervated by the alpha motor neuron pool. So it's an alpha motor neuron causes the muscle to contract. The spindle itself is innervated by a gamma motor neuron pool. So it's a different innervation. The interfusal fiber, the sensor, is innervated differently than the muscles that contract, okay? So that's kind of important, because as the spindle picks up stretch and the muscle begins to contract, the spindle has to contract as well, because if it doesn't contract, it becomes slack. As the muscle shortens, the spindle will become slack, lose tension, and then shut the muscle back off again, okay? Yeah. So the tension on the spindle is what controls how reactive that muscle is. So on a muscle that's hypertonic or shortened, the spindles are very tense and they're very reactive. That's why that muscle, think about the pectoralis major or the adductors or the quadratus lumborum. Those are muscles that are typically always hypertonic or tight. Then you think about muscles like the serratus anterior, the rhomboid, transverse abdominis. Those are muscles that are typically hypotonic. They have poor tone. Well, in those muscles, the muscle is lengthened, the spindle is slack and not picking up any tension. So those muscles tend to stay toned. Some of that's from spindle feedback. Some of that's from sympathetic tone coming into play. Okay, so that's a complicated way of getting to this point. The thing I forgot in the years of practice, because you get away from some of the science, I couldn't figure out why electrical stim, or a really strong sensory input, which is ARPneuro. It's a very, very strong sensory input, just a different form, just like myofascial work with an instrument is a sensory input. But why would sensory input change the neurological inhibition of a muscle? And then what I found is there's a sensory fiber, the 1A sensory fiber, it comes directly from the spindle and dumps into the gamma motor neuron pool, okay? So this gives constant feedback from the spindle to the gamma pool on how much tension is in that muscle, or what's going on, or what this is perceived, the state of the current state of the muscle. And that can cause the gamma motor neuron pool to keep the muscle at the right tone, the right length, and everything else. Make sense? So this is kind of the sensor for this. Now, what happens when I injure a joint? This was the key part. That's arthrogenic. Let's see if I can write it. You ever want to look it up? I can't make an M. I, like a 2-year-old.
Doing better than I would, Dr. Debono.
Arthrogenic muscle inhibition. It's a common finding with arthritis, joint injury, injuries to a joint. What happens in arthrogenic muscle inhibition? This 1A sensory fiber essentially gets inhibited and shuts off. So I stopped getting feedback to the alpha motor neuron pool due to a joint problem, okay? So consequently, when I have a knee arthritis, I start to inhibit the quadricep because I've lost this feedback from the sensory fiber. And this is common with most injuries, okay? So that kind of leads us towards, where was this thing? How do I shut? There it is. That kind of leads us towards here. Get off the simple diagram. This one's, I'll just go over this one briefly, just so we see. You guys see that okay? Jake? Yeah.
I can see it. Yeah, I can see it.
So here's that sensory fiber I was talking about that connects with the alpha gamma motor. It comes off the joint and then it connects with the alpha gamma motor neuron pool that actually controls from the spindle, okay? When I get a joint injury, this feeds back into a reflexive loop. This is at the spinal level only right now. There's a reflexive loop that comes back and inhibits the muscle again. So as the joint gets injured, there's a reflexive loop to inhibit the muscle. So the longer that muscle is inhibited, it's going to lose strength and not fire as, not fire on time like it should. We start to lose muscle firing patterns too, because we have an inhibition of a muscle from a joint injury. Now, this is a reflexive neurological inhibition. Here's the other issue though. As this becomes long-standing, this will actually go up from, it'll go to the sensory motor integration systems of the brain. So now I'm starting to get plastic changes in the brain. What these little yellow dots start to recommend is now the brain will work for a plastic effect to figure out, well, this joint's not moving correctly. How can I get it to move correctly? Again, the body reacts, it doesn't think. But the brain will start to figure out patterns of, let's say this is the glute med, and I'm getting it, it's getting inhibited. The plastic effect of the brain will be, well, let's fire the tensor fasciae lata, which is the secondary mover for the glute med first, because that'll get the hip moving into abduction. So for the chiropractors to do a lot of looking at firing patterns of the glute versus hamstring, that's an easier one, to the glute max versus the hamstring. Typically the glute should fire first in hip extension, and then the hamstring should fire. Most times we see patients with really bad low backs, hamstring fires first, the glute fires second. Sure. So that represents a dysfunctional motor firing pattern now too. So now I'm setting myself up for a hamstring injury and then possibly a back injury, because now I'm not stabilizing the back with the glute like I should. That's the plastic change that occurs in the brain. So now I have changed a motor firing pattern in the brain. All right. So what do we do?
Just to kind of conclude on that, just layman's terms, basically this is how a lot of these compensations are developed, sort of like what Colin was talking about. You get these compensatory patterns where the wrong muscles are absorbing force. Is that correct?
Right, because you know when we talk about, like, you get degenerative joint disease of the knee, right? common to get arthritis in the knee. Why it's common is because we start to change these firing patterns, and we can go into like what's called a lower cross pattern, where the adductor becomes tight, the glute becomes weak, and we start to get a lot of internal rotation of the femur. As that occurs, it throws my knee into valgus, which puts more stress onto the medial condyle. Well, 90% of our weight's borne on the medial condyle normally. Now I'm putting 100% on the condyle. So when I talk to students about how we get degenerative joint disease, it's abnormal stress on normal bone. Okay, so now I'm putting more abnormal stress onto the medial compartment of the knee. Well, of course, I'm going to start to fray the meniscus. I'm going to start to, tear up the medial collateral ligament. I'm going to start the process of degeneration. If the knee doesn't want to do it, the foot's going to get thrown into pronation. Now I'm going to start degeneration into the ankle as well, or pronation issues as well.
Yeah.
So correcting those patterns stick us into, and that was one thing that they were saying beginning. It gets the body to absorb shock better, and it's true. It gets to absorb shock better because I get my mechanics straight. This is the slide I really did like. This is my last one, so I'll stop sliding you guys to death here. Can't help it though.
It's good to see the visual.
So here, let's take there you go.
I just said I'm a picture guy, so it's good to see what you're actually saying.
I know you like playing with crayons, Jake. So here's an example of
my desk here.
Here's an example of ACL injury. This could, and we could fill this in with anything: degeneration of the knee joint, osteoarthritis, medial collateral sprain. Take your pick, but an injury to the knee. Okay, we're picking on the knee because everyone's kind of familiar with it. First thing that kind of happens, you get swelling, pain, deafferentation. This is the part we start to forget about. We start to lose sensation from that 1A fiber I talked about earlier. So we start to lose feedback from the muscle spindle. So now we're getting a reflexive inhibition pattern coming into play. That first pattern I showed you, that reflexive motor inhibition at the cord level. So now, because of the injury to my joint, I'm starting to shut the muscles off around this. The quadricep, the hamstring, they're all starting to get into inhibition patterns, neurological inhibition. So that impaired somatosensation now travels up to the brain, and we start to lose proprioception, reduce feedback from the muscle, activation of the joint. That all gets processed in the sensory motor integration centers of the brain. Now the brain will try to figure out how to compensate for that. So typically this is where substitution patterns come in. In the quad, the adductor seems to really light up. That's the one that tries to take over everything. That's why we get so much internal rotation with when we get an injury to the knee, internal rotation of the femur. Also, the rectus femoris, the vasti tend to shut off, and the rectus femoris, or the hip flexor portion of the rectus femoris, really seems to try to take over everything. So what practitioners have noticed who've done a lot of physical medicine, if you hurt your knee, their hip flexor really starts to light up. It starts to light the hip flexor tightness, adductor tightness. Consequently, the glute side all starts to shut off as well. Now, some of that comes from the patterning. If I really start to shorten my adductor, my adductor of my groin, the antagonist will get inhibited, not just through this impaired afferentation, but through simple reciprocal inhibition too. Because as I tighten a muscle, I tend to inhibit its antagonist. So now we're setting up this big, messy pattern of the knee doesn't know where it is, or the knee doesn't know where it is, and neither does the brain. So now it's trying to figure it out by doing these. What's interesting, see, these patterns are very repeatable. Drink of water. These patterns are very, very repeatable, and they come in, if you look at the work of Yonda and Levitt, they come into specific patterns. Now, this keeps going on. We start to get muscle atrophy, muscle weakness, and altered biomechanics. This starts to become the normal for the brain because now it's adapting to a bad pattern. Okay. So we have to be careful. One of the mistakes I see a lot of students make in the clinic sometimes, and even early, chiropractors coming out, they come in, they say, well, your glute is really weak. I'm going to give you exercises to strengthen your glute. Can't do it. Shouldn't do it yet, because now you're just reinforcing the bad substitution pattern. So you have to look for and break that pattern first before I start rehabbing the patient. I can't strengthen the glute. It's shut off. It's inhibited. So I have to get it to turn back on again before I do this. And then the other fascinating thing that I saw, and this was out of a physical, I think this was a PT journal where I got this from. There's a lot of psychological adaptations that come into play once we figure this out, particularly patients who have low back injuries, where we start to shut off the central integration to the low back. They can get a lot of non-use learned behaviors like, well, my knee doesn't bend this way, so I'm going to stop bending it this way, even though it can bend this way. Or fear of pain is a big one, particularly in low back. And I've seen it a lot with hamstrings too. People trying to come back from a hamstring injury is like, oh, I can't do that. It's going to hurt my hamstring. Now that's your key, that it's a fear of pain issue when they say, I can't do it because it's going to hurt, which means they're not even going to try it.
Correct.
And then disability, depression can come from muscular. So this cycle keeps going on and on and on. And if you just sit here and put ice on the knee and do whatever you want to do, it's not going to touch this stuff. Where I think ARPneuro had a really good, what I was really excited when I saw this is, there's your key, disinhibit the motor unit pool. Okay. Now, before I found ARPneuro, my approach would be to dump a lot of sensory input with myofascial work, either with an instrumented soft tissue, going onto the adductor to try to wake up the abductor, using agonist antagonist strategies. Okay. But it's a lot of work and it's not really comfortable for the patients. If you have had a soft tissue work done in your your adductor or your groin, you're not going to forget that one.
It's not fun.
That's
not fun.
But what's fascinating with this is, so I had an ankle issue similar to that, and it was I had my hip replaced on the left side, and then my right ankle just got torn up. I don't know what I did, but it was going on for a while. So I was trying every soft tissue thing I knew in the world. When I finally got it through my thick head to throw the ARPneuro on it, it was literally 2 weeks and it was dramatically different.
Wow.
And I think what it really was just dumping in so much sensory input that well, this is a hypothesis, but it seems to be waking that 1A sensory fiber from the spindle back to the gamma neural, reestablishing that connection back again, and then breaking this cycle.
Got it. So Dr. Debono, given what you've learned with this technology, we had a question come in. There's a few of them, and I haven't overlooked the other one, but we'll get to that in a second. But one of them that did come in, it's an interesting one. So I just want to pose you with the question, knowing where you came from and with your research and what you've learned, if a patient were to come to you with, let's just say, an ACL injury, what would your first act of treatment be with using the ARP?
Well, it depends. I mean, if it's ACL insufficiency, where it's just a sloppy ACL versus a frank tear. Okay, if they tore their ACL, this was an acute tear of the ACL, I'm going to probably co-manage that with an orthopedic surgeon because that may need to be surgically repaired first. Okay, because a complete tear is not going to heal on its own.
Correct.
Right. But then again, it depends on the patient. If this is a sedentary older individual who is not active, it's a tough call. But most people are going to tear their ACL. That acute tearing, they're probably not coming into a chiropractic office because that is, if you've ever seen an acute ACL tear, it's not very pleasant.
Yeah.
But conversely, what you're asking too, Jake, I do see a lot of patients with so-called sloppy ACLs. In other words, their ACLs, they've damaged their ACL, it's intact, but they have some excessive tibial anterior translation. It's not acutely torn. I do think I would try the ARPneuro there to strengthen the quadricep because I think whatever they did to the ACL to get it to be so-called sloppy, in other words, it's intact but stretched, that that's going to set up that cycle of inhibition, and the quadriceps are never going to get back to where they should be until we break that inhibition. So I think it's well worth a shot to dump in a lot of ARPneuro to see if I can get the neurological inhibition to break. In all honesty, I'd probably I'd try the ARPneuro first to break the neurological inhibition. If that came back up again and was getting stronger, I may switch over to a combination of ARPneuro and blood flow restriction, which has been shown to work very well at building up muscle physiology itself because of the way the blood flow restriction works. So now I'm attacking it from two areas. I'm doing releasing the neurological inhibition, and then going to address the purely the muscle physiology side from like a blood flow restriction technique. Does that make sense?
Interesting.
I hope it is.
Yeah, it does. No, I think you did answer the question. You brought up something interesting as well with blood flow restriction, because I think you're the only one who has ever mentioned those two together. It almost seems like the opposite of ARP. Could you explain a little bit, those that are out there who aren't as familiar with blood flow restriction and some of the benefits that you can see while using this therapy as well?
Well, blood flow restriction, there's it was developed by a guy, it was actually a physical therapist for the VA. I think he was a physical therapist for the VA, to address limb salvage. It turns out when you restrict blood flow and exercise the area, if you restrict blood flow to the lower extremity, you can get muscle hypertrophy with a lot less weight. So a rule of thumb is in training, to gain muscle hypertrophy, I need to work out at 70% of 1 repetition max. So if my maximum squat is 100 pounds, to get my legs bigger, I need to work out with 70 pounds, right? Makes sense.
Sure.
Well, if I've injured my ACL, I probably can't lift that. I'm using lower weights. I'm using Jake type weights.
Fair enough.
If I've injured my ACL, I really can't squat 70 pounds because my ACL is injured. Well, it turns out if I restrict blood flow to the lower extremity by 80%, it only takes 20% of 1 repetition max to get the same effect as 70% of 1 repetition max without blood flow restriction. So I could work out with 20 pounds and still get muscle hypertrophy. There's a lot of muscle phys behind it that's explained very well. Owen's recovery system probably has the best unit, and that's the ones we were using at Logan as well. They're surgical cuffs, and they can get you down to 80%. You'll see them in the gym sometimes. Of course, everything gets kind of, people using belts and straps and a little bit dangerous. You kind of really can't tell what 80% is.
Yeah.
But I think when we're attacking something, we have to look at what we're doing. And I think, again, ARPneuro, I don't think I found a better unit to break neurological inhibition than that. The way I was doing it before, you can break neurological inhibition with myofascial work. Again, it's a lot of work. It's painful to the patient. This seems to be a lot faster and a lot less pain. Plus, with the take-home units, they can keep it going.
Yeah, absolutely. We'll kind of get into the PRS and the take-home units. We get on that every other week as well. But another question that came in, I kind of want to pose it to you. What type of recommendation would you give to other doctors out there in their clinics, and they're looking into bringing in ARP for best practices for their clinic? What would you recommend to them?
Well, it depends on the clinic. I mean,
certainly
it depends on the clinic.
Well, and certainly what your studies are, like what you've gone through and what you know now. You're saying it depends on the clinic.
Well, it depends on the practitioner. I take it that way, because this is used by physical therapists, chiropractors. There's a variety, athletic trainers, a lot of people using it. I could speak from the chiropractic perspective how I would view it, because I'm a chiropractor. From a chiropractic perspective, that activation of muscle spindle fibers, that resetting of the spindle fibers in the periphery to break that reflexive loop is key to getting that limb stronger. There was a recent, and I'm going to work with ARPneuro on writing this up too. There's a recent systemic review by Heidi Havoc that looking at the effect of muscle spindle fibers around the deep muscle, the deep lumbar muscle, the deep spinal muscles, the muscles that surround the spine. And it seems with chiropractic adjustments has a profound effect on the muscle spindle activity next to the spine, the afferent flow into the spine of spindle activity. So from my perspective as a chiropractor, what I would be excited about is not only am I hitting the peripheral afferents coming in, the feedback coming in, I don't want it getting screwed up in the spine when it gets to the spine and there's a problem at the spine. Because remember, we're going to start changing spine mechanics now too, because we're changing lower extremity mechanics.
Right.
So I want to make sure that entire afferent pathway is open and clear going to the brain, or going up.
Understood.
So I think it fits really well into practices that do particularly spinal manipulation, because now we're all that spinal manipulation seems to have a profound effect on that afferent flow in the spine, similar to what we were talking about in the extremity. Now I can't get the ARPneuro pad on a deep lumbar, those deep lumbar muscles, but the HPLA seems to do the same effect that we're doing with dumping that much sensory input there.
Understood. Yeah, thank you. So we're running out of time, and I can't like end this without actually asking about blood flow, because I know you've been doing a lot of research on that as well. So I apologize for the hard pivot, but what have you discovered as far as the blood flow feature? And I know we talked about it like last week, and then where you've come to that. What are the benefits? And what would you suggest you can use this blood flow feature for? Like, what patients would you recommend that for?
Well, and I think anytime we're gonna, so some of the questions get, well, is this just like Russian stem where you cause a contraction? It's not though, because this will get to the blood flow piece of it too, because particularly the RX1 and the PRS, which is 245 times seconds, the RX is 500 contractions per second. That's a lot of stimulus very quickly. And when they first told me that, I said, well, man, this really has to hurt. Because I'm thinking back to Russian stem.
Sure.
And when I did it and I turned it up, I'm like, it's not the most comfortable thing in the world because you're contracting a muscle fairly tightly, but it's nowhere near what Russian stem was. I mean, as far as pain that it generated. And I worked a lot with looking at how this is wired, and it's what's similar to, it's a DC current, but they run it through a resistance capacitance circuit. So by doing that, that kind of creates a signal that's similar to what the body creates itself. Because it turns out that neurons themselves, and you can look this up on the internet, well, there's a reference on the website. Neurons, how they propagate a signal is a resistance capacitance circuits. Neurons have resistance and capacitance built into. Capacitance means they can hold a charge. It's like when you shut your phone off and the light slowly starts to fade. That's the capacitors. Right. So that slow fade is the smoothing out of the charge. It's just not cutting off. Anyway, it seems that waveform that they're using allows you to get really strong contractions without a lot of skin discomfort or that hard tetany that comes with Russian stem. Okay.
Sure.
So if I'm getting these hard contractions coming in, I'm going to get increased blood flow to the areas that's contracting because the muscles are working. And now I'm going to start to vasodilate because oxygen demand is going to start going up with these muscles constantly contracting. That's great, bringing a lot of blood flow to the area. But now I got to get it out of there. It's always good to bring it, but now I got to get venous return to take it back out again. So what turns out is it's on again, these references are on ARPneuro and on the Modus sites too. It turns out there's a couple of studies from Korea where they were looking at just doing a sensory stimulus to the sympathetic areas, particularly along the thoracic spine where the sympathetic chain lies. But what they found is, so this is subcontractile, it's only sensory. And some of it was even subsensory where you're not even feeling it, just running a light current through this.
Right.
What they found is that it increases sympathetic tone. So your resting tone of your muscle starts to increase by this subsensory or sensory stimulus. Oh, my watch is trying to tell me what's wrong with me.
Siri's just spying on you.
Yeah. So if I increase tone, I increase venous return because the muscles are at better tone and it's keeping the veins. Remember, venous return is largely controlled by muscle contraction. But if I have a better toned muscle, I'm getting better venous return without vasodilation. So that started to make real sense to me with how we could use the PRS. We could do a session of really strong contractile. And that's how actually I've been using it on my ankle to rehab, because my ankle rehab, I've been putting it on the ankle itself and then on the calf itself and doing some pretty strong contractions for about 20 minutes. And then just letting that sensory, the main signal suspend pulse, which is the subsensory pulse, stay on. And it's been phenomenal at keeping it not swollen, getting better blood flow return.
Nice.
So the contractile portion of ARPneuro brings a lot of blood to the area. And then with the PRS, that main pulse suspend, I think is working really well in clearing out some of the venous return.
Nice.
So I think
how long are you keeping blood flow?
What's that?
You mentioned that it's about a 20-minute contraction period. How long are you keeping it on that main pulse suspend function?
Typically about 20 minutes typically about 20 minutes to an hour. Depends if I fall. It kind of depends if I fall asleep or not.
Yeah.
That was the key.
Understood.
I hope that I know we kind of flew through that part.
No, that 100% answers it. I think there have been a lot of questions in the past in regards to like what I can use this device for at home. It's kind of a segue into the last question that came up is, once someone uses the device, do they have to continue to use it to stay, to have a successful, healthy outcome? But I think based on, you're talking about treating your ankle, then there's always blood flow. There's always a good reason to kind of have like maintenance treatment. Is that true?
Well, I think though, it's a great question. That was always a knock on chiropractic. You have to come in for the 3 times a week for the rest of your life, which isn't true. I think if you've broken that we slowly fall into bad dysfunctional patterns. It takes us a little bit of time to come out of them too. But once we're out of them and we realize that we're doing well, and I think it's good to get a checkup to make sure we're not drifting back into it, going all the way back into the bad pattern, which is the base. Now that's not once a week. That could be 3-4 times a year where we're just checking up on someone who's active. And most athletes get checked up every 6 to 8 weeks just to make sure we're not getting an injury. The number one predictor of a musculoskeletal injury is previous musculoskeletal injury. That has been true for the last 20 years, which means we're not treating it correctly. Whatever we're doing isn't taking care of the problem. So I really think if you've done a good job with the ARPneuro and whatever other techniques you're using, particularly if you're chiropractic, the spinal manipulation side, getting the central afferent stuff in, and that patient is, because you can tell dysfunctional patterns by their motion patterns, by their movement patterns, and they're keeping those movement patterns and it's not breaking out. And then you're retraining them, they're getting stronger during it. You're probably fine for a while, and just, get a checkup and make sure it's staying that way.
For sure. Yeah. Yeah, definitely answers the question. I know there's a lot of students that are watching this, and they'll probably watch it afterwards, and your opinion is going to really matter on this. So what suggestions or advice would you give to students that are coming out, eventually are going to become doctors, they're looking into this technology? If you were a young doctor coming out at this point, like what advice would you give to yourself, so to speak?
I think that would be it, is to go shadow maybe somebody doing this to see what kind of outcome they're getting. I would really, some students, depends on where, how your understanding of what you do, physical medicine is actually working. I'm a big whole body guy. I think everything's a system. So, and over 30, like I said, 33 years of practice, when somebody comes in with knee pain, typically the knee's not the issue. You know, now that's maybe where the injuries resulted in, but it came from somewhere else. And if you can get that cemented in your head as a young doc or a young student coming out, to realize to go look at the entire system, to go find out the source of that mechanical pain rather than just trying to alleviate the pain. We've done, you know, as part of it's, you get trapped into chasing pain. Well, this hurts, let me go over here, and this hurts, let me go over here. Or you're treating, I'll give you a quick example. Yesterday, I was working with a student who had a car accident, and she was complaining of a lot of left-sided shoulder pain. But it's been there for about 6 to 7 weeks. When I examined her, you know, and this was actually during a lab period, it wasn't during a regular clinic thing, where we did some evaluation on her, all of her motion deficits, she had an upper cross on the right and upper cross on the right side of her shoulder, right, upper cross right and a lower cross right, which is a little bit of an odd pattern typically. Anyway, most of her findings were right-sided, you know, decreased range of motion, tight adductor, tight pec, all right-sided, but all of her pain was left. So I said, well, try this. Let's do all right-sided treatments, focus everything we're doing, fascia work on this. I didn't have the PRS with me so we didn't do that. Yeah. Do all the fascia work the way I do the regular stimulus work, and then see how she does. Well, sure enough, we finish all the work. She gets up, she goes, well, my left side doesn't hurt now. It's like the first time in 8 weeks, it doesn't hurt. That's the cement we have to get in, is like treat the cause, don't chase the pain. And that's why I really like if I had the PRS with me, I would have put it on her pec and her adductor on the right side. I wouldn't have touched her left side. Yeah. Because that's not where it was coming from. That's not what it was showing me. But that takes a lot of experience and a lot of faith in your ability to pick up these subtle dysfunctional findings. So the advice to students coming out, get with somebody who can understand that approach. We're going to treat the cause and don't worry about where the pain is right now.
Love it. Absolutely love it. Dr. Debono, always a pleasure. It's never enough time with you. We always want you back. We like to stick to kind of our hard hour. We don't want to go a little, too much longer than that, but we'd love to have you back if you're willing to do so. I mean, I think there's just so many more things to cover. And I think at that point, you'll end up coming across other things that you'll discover that, you'll be happy to share about. And we want to hear that. So one last question, you sort of went into that anyway. Where do you see this technology, given what you've learned? Where do you see it going with the chiropractic industry in the next 10 to 15 years?
Oh, I think it can become an integral part of practice because it's doing a similar thing to what we're doing with the spinal adjustment. One does not replace the other. They both complement each other too. So I don't want the chiropractors thinking, well, I'll just use this thing and I don't have to adjust. And that's not true. I think both of them are such a strong complement because they're both strong forms of sensory input. And I think it's going to improve outcomes because I think it's going to drive a lot of chiropractors who maybe got, sometimes we just get stuck into a practice where we're just, your shoulder hurts, let me look at your shoulder. Instead of saying, look at everything. Let me see where this pattern is coming from. Right. And we're working a lot here with and I'm excited to work with ARPneuro on this. We're looking at a lot of quicker evaluation techniques to figure out exactly what these common patterns look like. And hopefully we can work to start to publish that with the ARPneuro site. Is like, do these maneuvers and this will tell you this. Because about 80% of these people all have similar patterns. And it doesn't take long to find them. I think what will scare some of the older chiropractors on here, older physical medicine people, is you're not going to make me do, a full functional movement screen, a selected functional movement screen, because you can't do it on every patient. You don't have the time.
Right.
But these patterns all come out with specific things that are fairly easy to pick up fairly quickly. If it's not working with what you're doing, then you could jump back into the more complicated assessment systems to look for, is there a subtle pattern change I'm missing? Does that sound? So I really think it's going to be a game changer as far as much better outcomes.
Perfect. I love
much
it.
Longer lasting outcomes too.
I love it. And I love that people like you, with your brain and your ability to be able to research, have their hands on it finally. And we can get even into more depths of what it can do. So everyone who's listening, make sure you check out Modus Methods. What is the actual website on that, Dr. Debono?
ModusTherapeuticMethods.com.
ModusTherapeuticMethods.com, ModusTherapeuticMethods.com. Dr. Debono, real privilege to have
Before
you.
you leave, I got to give one quick, I see that they're on here. Maybe he's on here. So the next one we have to do with the extensive history of Phi Sigma Kappa. So somebody on here will know what I'm talking about.
Fair enough. We'll keep that in mind on the next one. We can put it as the title.
All right.
Anybody else who has any other additional questions, I know there was a few we didn't get to. We apologize for that. But make sure you check us out next week. Next week will be Monday at 7 p.m., I believe. Do I have that right, Colin? I think it's on Monday.
Yeah, that sounds right. Yep.
So make sure you check it out there. Also, ARPneuro.com. And that kind of answers a lot of the questions you may have. It goes into detail of some of the things that Dr. Debono has talked about. A lot of his research, going to the science side of it, that's continuing to grow thanks to a lot of hard work that has done by him and some others that are coming up as well. So we appreciate these people doing all this, and we're really excited about the future on where we're going. So anything additional you want to add, Colin?
Check out the website. Check out, we post a lot of cool stuff on our company Instagram. That's at ARPneuro, ARPneuro. A lot of cool videos, pictures, just sharing different outcomes, different content from all types of people, practitioners, patients that are utilizing this throughout the country. So if you want to kind of see what it looks like in action, go check that out along with the website.
Fantastic. Thanks a lot, Colin, for filling in. It's good to see you as always. And everybody else, thanks for being here. And again, make sure you check us out again on Monday. And one more thing, check out say again, Dr. Debono, Modus Methods.
Modus Therapeutic Methods.
Sorry, Modus Therapeutic Methods. Thanks again for your time, Dr. Debono.
Sure thing, Jake.
We'll see you guys next time.
Awesome.
Okay.
Thanks, everybody.
Take care.